Hello and welcome to today's webinar. I'm Sarah Allen, Associate Professor of Health Policy at the Institute for Health Policy Management and Evaluation with the Dalla Lana School of Public Health. And I am the Director of the North American Observatory on Health Systems and Policies, a research center and collaborative network across Canada, US, and Mexico, and with global partners internationally. And I'm here also in my role as the lead of the resilience theme of the Institute for Pandemics across university institutional strategic initiative, interested in conducting research and capacity building and knowledge translation to support resilient health systems and preparedness for emergencies like pandemics. So it's my great pleasure to kick off today's webinar. And we're going to be hearing from international scholars and leaders in health systems and policy. And we'll have some time to engage with participants today. And so to get started, I'd like to start with a land acknowledgement. And Dalla Lana School of Public Health at the University of Toronto sits on the land that for thousands of years has been traditional land of the Huron-Wendat, Seneca, and Mississaugas of the Credit. And today, this meeting place is the home to many Indigenous peoples from across Turtle Island, and we're grateful to live and work and play on this land. And I'll credit the art on this slide is a famous Indigenous painter, Alex Janvier, who was a residential school survivor, and his artwork is now in National Gallery, and this piece is in the Canadian Museum of History. It's called Morning Star, and he's one of my favorite painters. I encourage you to look at his work and other talented and incredible Indigenous artists living and having lived in this on this land. And to just orient you to today's webinar, it's just a Zoom meeting. So in that spirit, we encourage you to keep your mics off and cameras off just during the presentation. And then we can use Q&A or chat feature to ask questions where you can hold them to the end. We have lots to cover. And so we hope we can get through our presentations and then have lots of time for questions. Please type them in the chat and we can cover them as much time as allows. We're recording today so we can make this available on our websites for future viewing. So just to orient you a little bit to why we're having this webinar and the group of people in today's session, we've had some support from the Northwest Healthcare Properties REIT that has allowed us to launch a network of comparative health systems and policy research and training, initially starting in Canada and Australia. And recently we've been really delighted to expand to Brazil and to Denmark. And this work is really to leverage the existing capacity for health systems and policy research within these countries, but to draw connections across our jurisdictions to enable the type of learning that we find so useful to inform our own policy reforms and decision-making in our own countries. And our current research agenda is really focused on learning from primary care reforms, their experiences, successes, and failures, and focusing on governance as one of those major sort of policy levers for change in health systems. So you'll hear from members of this group today, and we're excited to introduce this team and to invite others to collaborate and partner with us in this space. So today, it's a short webinar. We're packing a lot in. We have part one is sort of, I've broken them largely into two parts, but the first part is hearing from our principal investigators in Australia and Brazil, who have only a short time to cover a lot of content, 10 to 15 minutes or so, to really provide some highlights on the health systems context, some current challenges and priorities, providing maybe some illustrative examples of reforms in primary care, and sharing their thoughts on where we have potential opportunities for learning and comparison. And then my colleague Steph Tan will be presenting some lessons for Canada, sharing some findings from the work that we've had underway, both funded through this network, but also through our partners, including the Institute for Health Economics, that she's going to be presenting some work that we did in partnership with them. And then this will hopefully lead us into our fruitful Q&A, where we can walk away hopefully with some new ideas on how we can learn from diverse jurisdictions that are not our closest neighbors, but often are the countries that we turn to for ideas and innovations and inspiration. So to introduce briefly our speakers today, we'll start with the morning of us in Australia. We start with Professor Carmen Huckel-Schneider, and I'll maybe save her bio for when she's loading up her slides so that we have moved through quickly. But then we will hear from Professor Eileen Buscat from University of Sao Paulo, back on our time zone on the sort of evening, afternoon. And then we'll hear from Dr. Tan, who's with the University of Toronto and North American Observatory. So those are our main speakers, and we will have hopefully some conversations afterwards. So I'm going to invite now Carmen to share her slides, and I'll briefly introduce her at the same time because it's a long bio, but I'll just shorten it up. But Carmen's the Deputy Director of the Leader Center for Health Policy, Economics and Data at the University of Sydney, Australia. It's kind of our equivalent at the Institute for Health Policy Management and Evaluation here at U of T, the University of Sydney, where she also leads the Health Systems and Governance theme. And she's an associate professor, has the position of co-director of academic education, and many other roles. And her areas of expertise include the application of systems approaches for analyzing health policy, including financing systems, institutions, and technologies, with expertise in health systems governance and knowledge translation and global health policy. Over to you, Carmen.
Thank you very much, Sarah. Hello, everyone, from a early summer morning here on Gadigal lands. I am located on the University of Sydney campuses, which are on the lands of the Gadigal people of the Eora Nation. And I acknowledge and pay my respects to those that have cared for this country for thousands of years and continue to care for this country, and pay my respects to all First Nations people that are also joining us today on this webinar. It's always a real challenge to give a very brief overview of any kind of health system, because anything that I've learned from years of comparative health systems work is that they are all very complex. But I thought for the purpose of the webinar today, I would prioritise the level at which services are provided in the Australian health system. And broadly, we can think of that in terms of services that are provided through local health networks. So these are public services that are run by a board-directed local health network. And these are the networks that run our hospitals, main hospitals, emergency departments in hospitals, also family clinics attached to hospitals, outpatient clinics attached to hospitals. They are generally funded through some kind of formula basis, partly from our centralised federal government, partly through our state governments, and have service level agreements with state health ministries. So this is the kind of services that all Australians can get free of cost as public hospital services. The origins of the funding are generally general government revenue, state-based funding. We then have a large chunk of our services that are provided through the Medicare benefits schedule. So this is a fee-for-service schedule, one payer, set from the centralised government. And these are benefits, fee-for-service benefits that flow through to primary care clinics and physicians that we're going to be talking about more today, but also to independent specialist care, a lot of diagnostics and pathology, imaging, for example. And these are delivered through various different business models that use that fee for service from Medicare. And Medicare is not limited. It is available, these Medicare services are available for everyone in Australia. We also have a sector which is private services sector. So there are also private hospitals and a lot of auxiliary and allied health are largely funded privately. So that is with direct billing to consumers, as well as private health insurance that can cover these types of private services. What's probably key to note in the Australian health system is that private health insurance is optional and available to cover private services. But if you don't have it, you will get your care through Medicare benefit schedule, subsidised services, or services that are provided through local health networks. So, for example, hospital outpatient clinics. Dental services are one, for example, that are largely within the private realm. However, there are some dental services that are also provided through local health networks in hospital outpatient clinics, for example, for those that are really unable to access those in private services, although the vast majority do. And I've also got on this slide here a few sort of extra circles of examples where there are funding and delivery of services that don't fit into any of those boxes neatly. And it's these kind of circles that are actually a considerably growing part of the Australian health system and part of what we see as broader reform trends. Aboriginal community controlled health organisations have been around for a long time in Australia. They receive a mix of funding, some through the Medicare benefit schedule, but also other grant funding, block funding, as well as service level agreements. We have a growing landscape of non-government, non-for-profit providers that also receive a mix of funding, particularly as we've had some major reforms in terms of a national disability insurance scheme and in terms of aged care or long-term care provision recently. And a lot of mental health services are also part of this mix. So that's a bit of a background, but I want to hone in for the purpose of this webinar on our primary care ecosystem in particular. So in Australia, we have around 35,000 registered general practitioners that practice in approximately 7,000 different clinics. And these are primarily Medicare benefit schedule funded. However, there is no restriction on the billing rates that general practitioners can charge. So this means that they run effectively small businesses with various different models, sole practices, group practices, corporate practices, some community-controlled organisation type practices. But what each patient is charged for a particular standard service is not limited. So we have a certain proportion of GPs that will not charge anything over and above what they receive fee for service from the Medicare schedule. But we also have a proportion of consults or services that will have an out-of-pocket cost over and above that. And those rates, the proportion of services that have an out-of-pocket cost, if they're going up or if they're going down, if we have practices that do only no out-of-pocket cost services, is something that is very watched both in the public press, the medical press, and our statistics, health statistics agency in Australia, because it's a bit of seen as very much an indication of the health of our primary care system, the extent to which those out-of-pocket costs are coming in over and above what the regular schedule is. We all have around 80% of Australians that report having a regular GP. Now, this is something that is a very Australian kind of term because it's a term that you use where there is no enrolment with a GP. So everyone can go to any GP where they can get an appointment for their primary care services. That being said, most people have a preferred GP or a regular GP, and this is another metric that is often watched in Australia. So in the most recent year, slightly over 3/4 of services are so-called bulk billed, another very Australian term, which means that a service was provided in primary care only at the cost of the Medicare schedule fee, and there were no out-of-pocket costs for Australia. So we have a range of different business models through which primary care is provided, largely fee-for-service, patient billing, as well as a range of different other incentives to primary care practices to aim to improve access, improve quality. We have a fairly comprehensive set of financial safety nets for accessing Medicare benefit schedule services. So the schedule itself actually has multiple tiers to it. So tiers for initial visits, and then if out-of-pocket costs reach a certain level for a patient, they will need to move to another tier where effectively the rebate will increase, and then there's another tier after that to try and limit total out-of-pocket costs within a year. We also have primary health networks, which are organisations that are funded from the Australian federal government with the goal of increasing access, quality, interaction, innovation within the primary care space, and they're also responsible for commissioning additional services, and so that can be also commissioning primary care practices to offer additional services. And of course, a key part of the landscape is also the College of General Practitioners and the Australian Medical Association, which both serve partly as training and accreditation and further education agencies, but also the college advocates for primary care providers and their rights and interests within the system. So, as with most healthcare systems, there are certain challenges that emerge from the structures and the cultures and also our context, unique context here in Australia, although the more that I do work with Sarah and Alien and others in this partnership, we see very, very similar kinds of challenges. So one challenge in Australia is around out-of-pocket costs for accessing primary care. So as I mentioned, bulk billing rates in Australia, so these no out-of-pocket cost services are around over 3/4 this year. This actually increased a little bit on last year. But we did see a real trend towards a decrease in the number of services that were bulk billed between sort of towards the end of the pandemic up until a few different changes were made to bulk billing incentives just in the most recent year. And this is tied to the next challenge, which is that of sustainability. So not only broad challenges in terms of the total costs of services that are funded through the Medicare benefit schedule for revenue and expenditure in Australia, but also sustainability challenges for actually running general practices or primary care practices themselves. So we do see over the last 3 to 4 years, more primary care practices closing than opening. And there are inequities about where that happens. That in part also means that there's a consolidation of practices, but it also means that access is reduced, and the primary care profession in itself is working through different ways to make running primary care more sustainable. We did have a period of time where there was a small number of large corporates that were running primary care practices, and we've seen a retraction out of the primary care space from multi-service corporate practices, in part due to the cost and sustainability. There are other areas that are more attractive for a sustainable practice, for example, in pathology and psychology. We also have challenges around complexity and disintegration, as you can see from that first slide that I had, the large number of services through these public hospital networks where you can go and there's no out-of-pocket cost at all and receive your services, and then a large number of services in the community sector that are funded through Medicare fee for schedule. You can imagine the extent to which those do gel or don't gel. So complexity in referral systems, oversight of patients that need to have multiple different places of care, and still no widespread use of a compatible single health record. Although we do have a single health record, but there's a lot of implementation challenges for that. And then we see this amplified, each of these challenges amplified in rural-urban divides. And I have on the slide here a population density map of Australia, and I think colleagues in both Brazil and in Canada will see similarities here that we have the vast majority of our population is concentrated in a few centres, but we also then have considerable areas of low and then very low population density as well. And this impacts in particular on having timely access to care. So in terms of addressing those challenges, there's always a constant tinkering, as well as some concrete attempts at making health system reforms. And I would say that in terms of broad reform attempts, we see 5 different elements that are often captured in various different combinations, in different initiatives, in different funding reforms, in different governance and organisation reforms. The first, I would say, is an increased move towards new commissioned services. So using commissioning as a way to channel both funding incentives and organisational incentives into existing services and practices, but also to encourage the growth of new services in new areas around wraparound services, in particular around urgent care in Australia in the last 12 to 24 months. And that the commissioning of services comes through both hospital networks, state governments, primary health networks, as well as the federal government, in order to identify and then fill gaps and incentivise increased supply. Another broad area of reform is around the idea of enrolment. As I said, there's no compulsory enrolment with a particular practice, service or district in Australia when it comes to primary care services. So movements towards quasi-enrolment have started to creep in as a real broad reform trend. Identifying patients, contacting patients, incentives to ensure that there is oversight and linkage between one patient and a particular practice or a centralised care provider. Another area of broad health reform is around e-health, virtual outreach, increasing use of telehealth, technologies for care monitoring, and also increased use of available data to improve health systems and patient flow in real time. A fourth one is around a broad trend towards better co-location, multidisciplinary care working together. That includes attempts and some very successful attempts at polyclinics of various forms, but also different mechanisms to embed members of workforce across various locations within a pan-regional scheme. And the fifth broad reform trend, I would say, is often indicative in various different initiatives. Currently is a trend towards localisation. So increased co-design with various different health service providers, consumers, community organisations at local level, more local priority mapping, more joint decision making and incentives to encourage that. So a few different reform experiences that highlight the way that these different sort of 5 different reform trends are brought together include, I would say, the primary health networks themselves. So primary health networks in Australia have been around since 2015 to 2016. There's 31 primary health networks now in Australia. That was actually a consolidation of a previous form of networks, which were called Medicare Locals, of which there were slightly over 60, and they were actually formed in 2009. They also had a predecessor, which was divisions of general practice, which had been around a lot longer, since the 1990s, and had formed effectively as clubs and groupings of GPs working together to increase the efficiency and learning of running general practices. And primary health networks I consider to be a considerable reformer experience in Australia, because they have really they're in a constant state of revisiting what primary health networks can do in terms of improving quality, engaging GP practices, commissioning new services, and being able to link a culture of primary care within a particular region. The second sort of group of reforms that I have here is around medical homes, which have brought together various different aspects of those reforms, but really have focused in on this idea of enrolment, or having a medical home or a central location centred around primary care for people's needs, particularly people that have complex needs. There was a trial of a medical home that did run for a few years in Australia, where there was an actual enrolment of a patient with participating GPs that included a capitation payment for a patient's care. The trial ran and had some successes in terms of improving patient experience in care. However, there are a lot of learnings from that trial. It didn't continue. It wasn't continued in the form of the trial. In terms of implementation, what the level of capitation could be, and a lot of implementation barriers to actually engaging with the model in terms of the way that primary care is run. What we instead have is a more recent and currently running version, which is known as My Medicare, which includes some voluntary enrolment of patients with a primary care practice, which then makes the practice and patient eligible for an increased subsidy and types of services, with a strong emphasis on telehealth consults as well. And over time, they are starting to increase the number of services that are linked if you have a My Medicare relationship. And at this stage, this is focused in on people of older age, as well as people that have a low income. I've also highlighted here urgent care clinics. I'm actually brought in a poster from Southwestern Sydney Primary Health Networks that's highlighting urgent care services in their district. What I find interesting about this poster is that you'll see that there is two different, so there are 4 different urgent care services that they are talking about. Bankstown, Gregory Hills, Liverpool, 3 places in their district, and another one in Campbelltown, and that they are branded differently. This is because urgent care services have been an initiative at the state level. So these New South Wales ones are stemming from an initiative at the state level, but there are also urgent care clinics initiatives from a federal level, which are the ones that are branded there as a Medicare urgent care clinic. These are commissioned services where existing services agree with a financial agreement to offer walk-in services with extended opening hours, with the intention to be able to capture low triage urgent care requirements. Because one of the barriers that has emerged to primary care access in Australia has been those urgent needs, but don't really need emergency department care. And finally, some commissioning examples. Once again, we have here an example that is collaborative commissioning, which was a very state-led example, and a more recent one actually just released, ready for implementation last month, and an Australian government, so federal, central government, a similar kind of initiative. This is aimed at a change in governance, very much a localisation as well as commissioning trend being brought together, where there's a requirement for local health networks, hospital networks, as well as the primary health networks, so those that are the supporting primary care practices need to make joint decisions together to commission new services. So very much indicative of that broader trend. I'm really looking forward to further discussions with the team and all of you because I do see so many similarities in both challenges as well as potential solutions. And in particular, I find that there is so much to learn when we are making similar kinds of journeys because each of those journeys is so very much incremental. We can easily look overseas and say, oh, they're already doing that and they're already doing that. But actually, in almost every case, everyone's doing it bit by bit by bit. And I think that there is real-time learning as we go along these journeys across each country.
Thanks, Carmen. That was a wonderful overview. You've given us a lot to think about, and we'll hopefully people can jot down any questions they have, hold them until they hear from Eileen. Professor Boscat, I'll introduce you while you pull up your slides. Thanks for joining us. Eileen is the Professor of Health Policy at School of Public Health in the University of Sao Paulo, Brazil. She's a physician with an MPH and PhD in public health, and her research expertise is around primary healthcare, regionalization, geography of healthcare, and policy implementation. So over to you, Professor Boscat. Thank you. Don't forget to unmute. Thanks.
Okay, now you can hear me. Thanks so much for the invitation for this 3 time zone seminar. It's amazing to say good morning, good evening at the same time. So, and they are ABC, Australia, Brazil, and Canada. So it's very difficult, a very difficult task to talk about, to show you our health systems in only 50 minutes. But I try to pop up things, to highlight things that I think that are very important to our research. And so, first of all, just a minute. It was working before. Okay. So our Brazilian health system point that is our turn point, it was 1988, when we have a constitution that changed completely the health in our country. Before that, what we have here, you have a very different, 2 different sectors, one that was for the poor and the people that does the work, that was public health. So you have small units that goes to the antenatal care, infant care, and tuberculosis and things like that. And then you have a very private sector that was huge, that works for the people that have work in the labor market. Okay, so you have two systems that goes in separate way. So in our constitution in 1988, we decided to go to a universal health system. So after that, health was understood as a universal right and a duty of the state. But there is a point. Our health system is called here is a unified health system. It's SUS that has we speak in Portuguese. So there was a shift in the conception of social protection. So we went to the social security. Another point that's very important is exactly because this process, it occurs during the redemocratization of our country. That is very different from you guys, because you are in a dictatorship, and then we change for a process of redemocratization that was completely tied for this movement of we have a universal health system. And then because of that, that was a lot of people work, a lot of social movements, a lot of things happens together, then we have a very special kind of governance here, because different for you, we have 3 levels of federation, not only the federal and the states, but also the municipalities. So we have here in Brazil more than 5,000 federal municipalities, and they all are they can run the system, they can do what they want, they can do law. So it's very difficult. So everything we decide, we have to talk and have a lot of governance to say, okay, let's do that together. It's not only 1, 2, 3, 30, it's 5,000. So it's completely insane. So, but it was we have here. Although you have, that's a point very important. We have to keep that in mind, that Brazil is extremely unequal country. With a very strong dynamic of social exclusion. So you have the north and northeast of country have a lot of parts that are very poor, the Amazon region, etc., etc., and you have a concentration of huge cities, that in the southeast, that all they have a lot of money, and and as in Canadian and as in Australia, most of our population nowadays lives in big cities. Although you have a lot of people living in very far away and remote localities that is very difficult to access healthcare. Another point that we have to keep in mind that although we are a universal health system, we still have a very important private sector. It's almost 1/4 of our population. They pay for that the private sector, and in the end, you can see the expenditure is not look like a universal system. More than half of our expenditure is out of pocket of families or and not for the state, because most of the people, they have to pay. Sometimes they have to pay, especially to for specialized secondary care and for hand exams, and also for some medications. So we have a very complicated mix and public-private here in Brazil that continues even after our constitution. Our law. Okay, that's the point that you have to keep in mind. So here is the timeline of primary health care here in Brazil health system. We have five moments. The 5 moments is out nowadays. So before the constitution, we have municipal experience that do a lot with very experienced in small cities, big cities, how to provide primary care that was to be different than that model of pediatricians, medical, clinical. You don't have general practitioners here. It's not a way that we look like more Americans. So you have the internships, the pediatricians, GGOs. That still is a way that our doctors are here. Then in 1991, that was a point that's very important, that it became a different approach to primary health care. That was what we called community health work programs. That is a point, that's a very different, that's a mark, a cornerstone. But what's the problem? That I will speak a bit about this later. That was focused in poorest municipalities. The hunger cities that are very, very, very poor. After that, we start to, that model was somehow good. So they start to expand to other municipalities with what called family health program. And then you have a lot when just before the pandemic in 2016, we have a lot of problems. We have a problem with democracy here. We have a lot, and then Dilma Rousseff was withdrawal. And then we have long-term austerity policies. That is very face a lot of problems in our social policies. All include health. Okay. So in all these years, we have a lot of models, a lot of reforms that try to improve our primary health care. Okay. Then I would like to show you the point that I think that's important, that our community health programs. The point that it was very interesting, this picture shows that our community health work, that you work not inside the health facilities, they work on the field and go to the population, talk to the population, they ask for a lot of things. But still at the beginning, we can call that a selective primary care, because it was only focused on the poor and don't have doctors in the team. You have only people that the community health works plus a nurse that was the lead that goes with the people. Then we have a change that was in 1994, that the family health programs is still in the poorest municipalities, but is began in the urban ones, and a physician was incorporated. So after that, as you can see, we changed for the family health program and for the family health strategy. You can see with the pictures that there are difference. In the bottom, you can see a building. So you say it's for everybody now, not only for that one that lives in the poor and that live in the rural areas. It's for everybody. And then so it was a model that we think that is very important, that not more a selective primary health. Now we can say that we have a primary health care. And a point that is very important for our experience here, that it's a combination, that's a very thing that is very virtuous, a combination between individual care and also collective care with the community health workers in the fields and also health surveillance. That is very different for that way that we have only the GP inside his place, and then the people goes there. It's a different form of improve and take care of the people. And we really believe that that's an important way to face social determination of health. When you go there and it not only go for the diseases and it'll go what's caused the diseases, how you can do in the field, in the municipalities, with a huge social participation. So that's very important. So I have to pick some things to talk to you about family health, our family health strategy, our primary health care. I could speak about how we change a lot of our morbid mortality of a population. It is a lot of things, but I picked two that I think that are very important, that it's access and equity. And then I will talk about the pandemic very quickly. First, access. As you can see here, darker is, sorry, it is in Portuguese, sorry. It is the coverage of family health strategy. When the blue darker is the blue, more we have the population covered with family health strategy. As you can see, it upscale was so quickly. It was not almost white in the beginning, and then you go and go and go. And then nowadays you have almost 6 to 7% of our population covered by family health strategy. And we will also have in some municipalities places that you don't have the family doctor, but you still have work in primary health care. So nowadays you have a very important coverage of the population of primary health care. Another point, so you can know, can say we have nowadays, Carmen said about 7 million facilities, GP practice. Here in Brazil, we have basic units that you call that basic units. Nowadays, we have finished a survey of all of them. You have more than 40,000 units in our Brazil, almost 50,000. That is a number that is completely huge in all the places we have them. Some are small, some are very big, and in all of them, we have a very important, we have dental care, we have doctors, nurses, community health workers, and a lot of things. And most of we have nutritionists, dietitians, and others that are improve the conditions of our population. And equity, we have a lot of problems here, of course. And I picked two to show you that we decided that was some innovation here. Here is the river units in the Amazon regions. It's very common to have fly in, fly out, drive in, drive out. Here we pick out navigation in, navigation out. So you have this kind of these boats that we have two models. One that are small units that stay in the side of the river, and then the people goes there. And you also have this beautiful and amazing boats that they go to the populations, and then populations go to the boat. If you can see in the bottom, the populations pick their boats, the small boats, and go to the big boats and go for doctors. So that's very important because that's our Amazon region was a lot, they don't have access that people. And so it was a very important way to improve equity in our country. Also, not going from the rural and the Amazon in the cities. In the cities, you have a lot of people that live on the streets, unfortunately. So we begin with this one that is the street health units. So you have people that goes there by car, and then these people can go there and have go to the doctor and talk and have medications and mental health, because unfortunately a lot of people here lives on the street. So there's only two kinds. And we also do a lot of other things that are very important. This is our national health survey. If we go to the houses and ask what are going, it's very interesting to show that we have high coverage family health strategy. The coverage was higher in rural areas than in urban, especially in the north of the country, so that equity is working. So, and the increase is, it's increased between 2013 and 2019. Unfortunately, it decreases after Bolsonaro periods, but nowadays we are going a little better. And we can see that most vulnerable people is better. And even racial inequalities, they are being addressed. They're not solutions, but they are less, they are not so big than they were before. So another point that is very important, they have a lot of common source. It's nowadays a lot of people in our country, they have a common source of care. That's our family health facility, our basic care unity. So that's a very important point. What's a problem that you have that we are trying to address now? It's secondary care. So secondary care is still privatization. They are only in great big cities, and it's very difficult. So we are working in regionalizations. Nowadays, you have in Brazil 120 regions that are trying to work out to can offer all the population, all the integrated care, all the integralization care. But we still have problems because it's not you can do. You have all that traditions, that the concentrations of the unities that now they steal, but we are improved. And after that 2016, what's the problem that we are facing? That was a problem, that was a change, a shift in the policy guidance. So the family health strategy that was so good, that don't spend a lot of money, that have good results in our health population, they decide they are not good enough. They decide that it would be good to have a doctor inside the unity and pay. So that was, nowadays we are living a very stronger a fight between two models. The problem that our primary health care, that it's our family health strategy, and the primary care that would be the traditional way of primary care, only with doctors and that way. And then it was that in this middle of this fight, the pandemics broke out. Also, it was crazy indeed. And then we conduct a research with our primary health care, and you create, just show a bit for you, you create an index that you call primary SAIPI, primary health care COVID. So we look for four axes that was treatment of COVID patients in our primary health care, the continuity of care in our patients that have to go with hypertension, diabetes, etc., and two dimensions to access, that is collective approach, that to be social support for people that need social support, and also health surveillance. What did you find? We find two distinct profiles that was completely amazing for the research, not amazing for our country. Two different profiles that the Southeast that better performed in the individual dimensions, and the North and Northeast if better performs in the collective dimensions. Show that is still struggling. So how you can improve nowadays, how you can improve the collective dimensions in Southeast and improve the individual dimensions in North and Northeast. It's one of our challenges nowadays. And then I put some of our challenges. One of that is actually that one, the model of primary health care. So we don't have consensus here in our country. We are fighting. Although nowadays the health minister, they decide for the family health strategy with few support, but in the society, it's still not so easy, especially by the doctors. You have a very important movement of the doctors, the physicians here, that is a far-wing movement that's completely, even here, they are against vaccinations. It's completely insane. Then you still have logistic and structure issues in our unities, in our secondary care, because you don't have the time, but most important, don't have the money to change that problems that began since this last century. Human resources, our workforces where a lot of problems because most of the time you don't have the formation of general practitioner here. So that's a problem. And all the regional inequalities, there's still a problem that I showed you about COVID and secondary care and the finance, don't have a lot. Our money here is completely very, very, very small money, very poor. We don't have money for do all we have to do in universal health care. And also the public-private relationship that here is still a very huge problem, although it's in private healthcare and all the systems, you don't have to pay. It's free of charge, but the relationships and public and private are very complex, and then they go much more than to pay or not to pay. They're very complicated. These are the challenges that I think that are very important for primary health care, and that I think okay.
Thank you, Professor Biscat, for this really enlightening talk. And we clearly needed an hour for each country. We really underestimated how much we could cover. So thank you for the overview and really highlighting some of these key challenges that are really similar across our jurisdictions, but with many opportunities. I love the geographic stratifying of strengths and in the country. That would really resonate. Dr. Tan is an assistant professor. She has about 2 minutes to present some highlights from her research just to whet your appetite and hopefully send us emails if you're interested in learning more. Steph's based here at IHPME and has experience in comparative health policy. Her PhD was in England, so she brings a lot of this comparative research background to the work she does in Toronto. And I'll turn it over to you, Steph, just for a few highlights. And I know everyone will have to sign off soon, but we will probably go a couple minutes over, and this will be recorded for anyone who has to hop off. Thanks so much.
Of course. Thank you for having me here. So as Sarah has explained, my role here in this partnership is to start to draw together findings from between the different countries and the early work that we have done. So I'm really looking forward to bringing some of our early work back to Canada and just mapping out and quickly describing the work that this policy network has done and what we're looking forward to doing and what we believe that are some of the challenges and enabling factors that we can identify through this comparative health work. So to begin with, I'm going to quickly go through some of the findings of a large scoping review we've been working on for the last year and a while. Then I'm going to, which is taking a long view over the past 20 or so years of reform. Then I'm going to speak more to some of the early findings from a recent policy dialogue we conducted across 3 countries, and then highlight some early learnings from across these policy networks for your interest. So first, I want to draw your attention to a scoping review that we started in September of 2022 that looks to uncover mechanisms about the impact of primary care reforms on governance accountability and really understand and really unpack some of these mechanisms to understand change and how they can be enabled across different parties. So far, our early work looked to compare Canada and Australia, and we're really excited for this opportunity to bring Brazil and Denmark on and start to learn from this comparative policy research network, just trying to understand, some of these findings, some of the benefits and drawbacks of different types of policy reforms. So we ran a huge scoping review, which gathered about 20,000 studies. So we've been in a long process of scaling it down, and we're really excited today because it's the first time we're actually presenting any of the findings from this work. So we are down to 83 articles from Canada and Australia, covering a range of years from 2002 to 2023. So we have a really long view of different reforms that have occurred. So in total, we find that the governance mechanisms that are covered by the majority of these papers really focus on the use of payment incentives, payment models, particularly new models of remunerations for family physicians and primary care models of work. However, we also find there's about an even split between that and incentives, specifically looking at trying to improve chronic disease management or incentives to improve access. We also find a large body of work that looks specifically at the use of meso-level organizations. We particularly find this in Australia. As Carmen has alluded to, there's a huge body of work about new commissioning models and new contractual models to reform and improve models of primary care. And we also find that there's quite a bit of work around health systems integration and performance management. So we're looking forward to delving into this and moving into the analysis and synthesis of this work over this winter, and hopefully being able to share some more findings the next time we have a team webinar in the coming months. So that is the work that we've been doing to take a long view over the last 20 to 30 years to understand where's reform going, what is happening, and what are promising mechanisms to develop policy change. Now, we drew on that work and some early work that was sponsored by the Institute of Health Economics out in Alberta to look at primary care governance and reforms and trying to identify promising models and approaches. So we conducted this work in 2023, and we built on it by turning this into a working paper. We invited participants from 3 countries, which included policymakers, clinician leaders, and academic researchers from Australia, Canada, and England to discuss what are some promising trends and developments in the in primary care governance and reform, so that we can understand a little bit more about how and what mechanisms are promising going forward. So broadly, I'm going to briefly touch on some of the our early findings are that primarily there's quite a bit of experimentation around governance mechanisms. These vary with, we find that some countries have focused, particularly some jurisdictions use a statutory requirement for collaboration, such as regional coordinate networks for planning integrated services and new ways of planning the health system. We see this through integrated care systems in England and Ontario health teams in Canada. We also see a wide range of voluntary mechanisms which use network-based approaches to support primary care integration. These are demonstrated through primary health networks in Australia and new primary care networks in Ontario. Importantly, we find that maintaining professional autonomy is extremely important, particularly for physicians and professional groups, and that governance mechanisms that support and maintain personal and professional autonomy are widely accepted, while they also allowing for experimentation with innovative new funding and business models. We also find a lot of interesting findings about the use of funding reforms to drive primary care reforms, particularly associated with remuneration and different incentives to improve access. which unfortunately, I've dropped that slide because we don't have time for it, but I really look forward to sharing some of these findings more broadly with us as we look to disseminate this work. And I want to close out by highlighting that there are important health systems challenges that we feel this comparative policy research network between Canada, Australia, and Brazil can really offer. And one of the first is that we're able to synthesize and identify learning from meso-level organizational reforms across different jurisdictions. We also think that we can hone in and draw out important policy enablers and challenges for the improvement of collaboration and the coordination of care. Next, we think that we believe that we can draw important insights about how governments and health systems and jurisdictions can pursue their policy priorities through different financial financing mechanisms, and that these can be combined to support more equitable access to primary care, which is ultimately able to advance the development and support of resilient and high-performing health systems. So with that, I want to close and pass it back to the general panel, and we'd be happy. We invite you to share more of your findings and come speak to us further in the future and be engaged with this policy research network.
Thanks so much. And sorry, everyone, for running over time. And thanks, Steph, for doing a condensed presentation. Obviously, there's much more we're happy to share. You can email me. I know Professor Dubinsky is interested in getting in with a question. And for anyone who wants to stay, we can take maybe one question from Dr. Dubinsky. Would you like to ask your question? And then maybe we can close formally.
Yeah, actually, it's kind of two questions. One is a question about Australia's private care. Is it totally privately financed, i.e., do the physicians themselves pay for the physical plant and all the infrastructure, or is it partially government subsidized? And the question for Hélène is a public health related question, which is, for instance, we read a lot about the destruction of the forests in Brazil, and there are obvious health implications of that, public health implications. What's the relationship between public health and government policy in Brazil?
Great questions. Carmen, do you want to take the...
Thank you. It's a really good question. There are, of course, a range of different complexities. I think one thing to note is that private health care that is delivered by your specialists, so your cardiologist or your endocrinologist, are actually Medicare benefit schedule funded services, right? So specialists in a private clinic come under the Medicare benefit schedule banner. The private services that are private hospitals are funded privately through insurance and patient contributions. However, there are also infrastructure grants and public-private partnerships for running private hospitals as well. So that is becoming increasingly common. And in the allied healthcare space, it is becoming increasingly common to have a mix of both Medicare benefit schedule funded services that's coming in for physiotherapists, people with chronic disease management plans, but still by and large, it is out-of-pocket private as well as private health insurance, which doesn't cover anything that's Medicare or public hospital funded. So it is still quite separate, yes.
Thanks, Carmen. And that the blurriness, the mixing is increasingly seen in Canada as well. So this would be another opportunity for learning how you've been able to navigate that in Australia. Hélène, do you want to take on the question?
Yes, that a big is another seminar. So the problem is not only Amazon. You have problems of the devastation in all our parts of our country. That's a rich problem. Some of our units, they face that problem because they have, nowadays we're facing drones, a lot of things that happen, and all the conditions of the population, they impact a lot. And we are trying, but even now, the federal government is not capable of stopping the deforestation of our forests. That's a point that I think that's interesting, that we, at that survey, we asked our facilities if they have some problems with climate changes, with some system, a lot of any problems. And then 20% of our UBS, they have our units, they have problems, and they have to change places because of our climate change. That's completely insane. In the 5 years, that's a lot. So we really have a lot of problems with that, and then I don't think that's a you are going in a good way to his solution that.
Thank you both.
Questions, and just thank you to our amazing panelists for joining us today and sharing some insights. This is just part of a much bigger conversation and research program, and we encourage you all to reach out to us individually, reach out to me, and I can connect you with the teams in Brazil and Australia, and of course us in Toronto. And just thank you for your time to our speakers, and thanks to everyone for attending. It was really a great learning opportunity, and we hope to have many more of these in the future. So thanks so much, and have a good day and good night, and take care. Be well. Thank you. Thanks so much.